Welcome, everybody. My name is Dan Cullum. I'm an oral surgeon. Welcome to the Academy of Osseointegration annual meeting and to this Noasis corporate forum. For disclosure, these are the companies that I work with as a consultant or as a speaker, and two of them I like so much I got stock in, and one of them is this company. So that's my disclosure. I stock own, but I thought it was outstanding investment, and so I'm going to share with you today what I've learned over the past few years in conjunction with. So we learn a lot in groups and relationships, and so we do a lot of fun things with skiing, and this is one of the heli groups and the CE we did with it. And we have a training center in Idaho for a second disclosure, so if you're ever interested in coming up to visit us, love to have you join us. And notice the far side of the screen. We really enjoy good wine in Idaho, so love to have you come join us. This year we have Mike Block and myself doing advanced crestal and tunneling, and in October Joe Kahn and myself sharing 25 years of what we've done with immediate implants. And so look forward to it. Immediate implants is 85% of my practice, and BioXclude is one of the things that allows me to do that predictably. So I want to share with you today these different components of wound healing and upregulation, which is going to be our first topic. And in this day and age right now, guys, we have to do some things that make our surgery predictable. And avoiding raising a flap is huge. So you're going to see me as a surgeon raise less flaps than Dr. Miller as a periodontist, and I'm going to share with you what I do, and you need to take home those things and figure out how it works for you with what you work with. So we can really do a lot by preserving the blood supply. So sneaky tips to be able to get things out with different shapes of proximators or X tools, and also sometimes piezo. One thing, if you're doing immediates, the far left is a micro rongeur. You have to have a rongeur with tiny tips to be able to get into the socket and get granulations out. So a few things like that that you just wouldn't initially think of, so you have to adjust your armamentarium. But I think we're all used to the training that we've had in the past with healing and sites, and we live with that every day. And so choosing our biomaterials, as Dr. Miller said, is really important in how we manage it. But if your practice is like mine, half or more of the patients now are coming to me as compromised. They're compromised in age, or heavy smokers. Vaping, the doses of nicotine that the kids are getting in the vaping is huge. And that's something that we can easily overlook. History of a failed site, failed endo, apico, fracture, that's a really common kind of scenario. And then we add systemic disease and medications on top of it. So these are the kind of wounds that we want to augment or enhance the wound healing at our sites with signal agents and cells. Well, classic cells is autologous bone with cells in it, so it has to be more marrow component. And also we have the ability to use different kinds of signal molecules. But we want to enhance the wound by getting more cells, either mesenchymal stem cells from the bony walls surrounding the site and or the periosteum, or we got to recruit them. So we've got this group of chemicals and mediators that we're able to use in BMP, PDGF, and ddACM. And I've used all of them, and I used DDACM or the freeze-dried Amnion-Chorion or BioXclude, which is Noasis's product, every day on almost every case. PDGF I use 3-4 times a month, and BMP I use about every 4 years. So it's that cost-benefit ratio, but we need to be able to upregulate wound healing. And so this simple product, which is processed Amnion-Chorion, and we'll show you that shortly, has a bazillion growth factors in it. And so right now there's more than 250, and I can't keep up because they keep discovering more. And so they're happy to tell you, but these are just a few of them. And the deal is that we want to see induction of epithelial cell migration and proliferation, and we want to see upregulation of wound healing and angiogenesis, which happens through this product. So this is a study that was in J. Perio and split mouth with a straight amnion product, and they showed a notable difference in post-op pain, just applying this amnion product over top of the wound when they did the bilateral study. So there was a significant reduction in pain. But the chorion layer has the most of the growth factors in it. It's got the lion's share, about 80%. And here's just a few you can see across the screen, the amnion and chorion components. So chorion is really important. So what we want to do is take the placental tissue and they process it through a Purion patented process, and they take out the intermediate layer, and then they're allowed to put the chorion, and that's also the part of the trophoblast layer that we put back together, and you get a very concentrated product without any freezing. And so a non-Purion processed amnion has about 5% or 1/4 of what a normal amnion has. And if you look at amnion and chorion together, you get a large amount of growth factors. Well, that's great, but do we know that it works? Do we know that it's released into the tissues? Is it released in a biological amount over time that matters? And this is 96 hours, which is considerably longer than PDGF and BMP, but it also has a sustained release by the degradation of the product over an additional 2 weeks. So we're getting a number of growth factors in biologic concentrations at work, and we're able to keep it in the wound for a reasonable time. Additionally, we've got this ability of amnion to be antibacterial, and AA, strep mutans, and oralis are all susceptible to it on agar plates, including strep gordini. So here's 4 bugs that are hanging around that it's actually toxic to. So if we look at that, do we have the ability to improve wound healing? Well, everybody talks about PRF. I use PRF, but I don't use it in implant surgery very often because it takes up more space to deliver less growth factors. So we'll talk about that. Additionally, there's some other amnion-chorion products that are now available. For years, there was no competitor, and now there are, and we'll talk about it. I think from a periodontal perspective, periodontists should be more excited about it than an oral surgeon because the healing when we have a typical wound, when we have a barrier, when we have PTFE, or we have an LPRF clot, the wound heals by the epithelial cells going underneath the barrier and healing, which puts the healing margin lower than when we put in an Amnion-Chorion or BioXclude. The healing happens on top of it, so it acts like the basement membrane. So that's 1.5 millimeters of difference in tissue height, and I'll show you some cases where it really makes a difference. Additionally, you can see just better quality of soft tissue and healing and very few problems with complications. So when we look at LPRF, the patient's own blood is the determining factor. So who do we need it on the most? Older patients with compromised sites and patients on tons of meds where their platelets aren't good. Well, those are the very people that when we harvest their blood, process it, that we get something better than their normal blood, but it doesn't have the same quality. So the cases you need it on the most are the ones you really need to have BioXclude on your side. If you look at comparing this photomicrograph, those are the same powers on the 3 products that are available. And on the left-hand side, you can see BioXclude, how concentrated and dense it is. The other ones have detergent-based solutions, and they're freeze-dried. And the freeze-drying is what gives them the heavier thickness because it expands it and fractures some of the tissue layers. So does it damage it? I don't know. I've used the other ones, and I've seen okay results, but I know what I get consistently, and when I have problem wounds, I want the best I can have at the site. So that's just a quick overview. In terms of the other groups, the agar plate or the growth of bugs, you can see that the bottom left corner is BioXclude, the top left corner is straight collagen, and the other 2 are the other 2 competitive brands. And so the difference in the processing makes certainly a difference on their ability to be antibacterial and kill things. The other thing that's been brought up is a trophoblast layer. Trophoblast layer is just the main layer that's in the chorion. And so that's already part of what BioXclude does in terms of managing the tissue with an excellent process that's been around for 20+ years on a product that's been used in human surgery for over 100 years. So this is a minimally manipulated product, so it has a different FDA classification than a lot of other allografts, but it's an excellent product. The other thing is that I do have patients that are concerned this is not a fetal not aborted tissues that have been through a tissue line. These are live birth C-sections on patients that were pre-done and tested before the product's released. So it's important to understand that. So there's no detergents, no precipitants, and there's no freezing, and that gives us an immunoprivileged tissue that accelerates wound healing, being anti-inflammatory and antibacterial. And as Dr. Miller said, the anti-inflammatory part is really significant when you see patients back at 3, 5, and 7 days. The wound looks way better than what you're used to without it. Here's an example of the product being placed on the healing abutment. Okay, and on the far left side, you can see the healing that's happened, and I'll show you this case in more detail. Here's an example also of a case in an immediate. And so, like I told you, 85% of my patients are immediate surgeries, including molars. And this is placed into the gap. You can see the healing abutment height on my side of the screen, and you can almost see the top of the implant, but it is palatal placed with a 3 millimeter gap. And in this kind of situation, you can see the amnion that's on the abutment and how it's healed up after 4 months to the height of the abutment. And that's a very consistent finding. If the implant is placed palatally, it works like a charm. If it's not placed palatally, it heals better with the Amnion-Chorion, but you're still reducing the potential healing. So look at this case. This is after tissue sculpting and placement of the implants, and we've got a 4 millimeter tissue cuff around the site where there was nothing before. So I think it gives us some abilities to really move through and do cases as a single surgery. So Robert pointed out, and I agree with him completely, the best crack I have to get something done is in the immediate wound. You have the best healing potential of the body, the best model, and if I can do it where I can get it as a single surgery, that really helps a lot. So Mark Lucas, who's a friend of mine and been part of BioXclude for a long time, we did a couple articles. One of them we just talked about socket grafting, and this is one of the cases that we did in it. And this is a lady that has a fairly significant midline asymmetry. They were sent to me to do implants. I looked at this case and said, nah, this isn't an implant case. This is a traditional pros case. They can work with camouflage and changing shapes and try to get her back to a normal midline. So we took the teeth out here. Again, no flaps, clean it all out. I spend more time cleaning out the site than I do taking out the tooth. And if they're dirty, I wash them out with betadine solution, not paint, and then I re-rinse and prep them. Here, this graft is in a place where we're not going to be placing implants, so I have a blended allograft and high-temperature xenograft so that I keep the shape predictably. So we place the graft material, cover it with the Amnion-Chorion, and then have upside-down figure-8 sutures. They can be PTFE or glycolon. Small wounds, chromic is fine, but you get molar sites that you're grafting, and there's too much glutaraldehyde in the suture if you have multiple passes across it. So I'm careful about when I use chromic, but I do use it around the sites. So here's an example just of early healing. And at 2 weeks and sutures out, you can see the kind of healing response that you get. This is nothing spectacular from this viewpoint. Most products would work reasonable in this kind of a wound, but the more compromise you get. So this is a patient in a provisional restoration, and you can see they were able to work with camouflage to get things back into a reasonable situation for her. And that was an example just of doing socket grafting. Well, some folks say it's hard to handle. I don't find it hard to handle. You carry it to the wound dry with dry forceps. You soak it in the wound, and then you tap it with wet forceps and move it around. If you've got blood or anything on your tips, they'll stick like crazy. So you just have to make sure you wash, rinse before you place it, and then you're able to go. Passing sutures, the upside-down approach where you come from the palate through the palatal side, and then from the buccal aspect through the buccal side, and then tie an upside-down suture. I've started using it in a lot more wounds. It doesn't knock out your BioXclude and allows you to get good closure. So let's look at a GBR kind of application. This patient has an existing implant in a lateral incisor and has some external resorption and ankylosis of the canine. Great situation, right? So I had to do a full-on to get it out. So I normally would not do any flap, but that's what I had to do, and we're trying to preserve a 3 millimeter proximal bone to the adjacent implants so that we have a predictable reconstruction. So this is a significant defect, and with it, grafting, cortical cancellous allograft. Sometimes I would put a small amount of xenograft on the buccal as a layered approach. Here we're covering it with the BioXclude, so we get that in position, and just reapproximating the wound margins, and on the green arrow, that's the original opening of the tooth. I'm not trying to get primary closure. This product in 7, 8, 10 millimeter defects will migrate, the cells will come right across it, but you can't use all xenograft. It has to be an allograft or a blend with a small portion of xenograft, preferably porcine as opposed to bovine and not high temperature. So there's a number of reasons about that which we can't jump into today, but here's early healing, and you can see the limited kind of inflammatory response, and you watch as it heals up over time. So now we have to get an implant into the site, and so we've gone through, prepped our implant. We'll add a little bit of graft material to the crest just to re-augment it. So anytime I'm placing an implant in a site, I add a little bit extra graft around it, like a contour graft, cover it with the Amnion-Chorion. I shape it a little bit, make it 25 to 30% bigger, and the cuttings I put as a single layer, as a triangle underneath where I need the most doses of growth factor. It's not like a barrier. We have to change our process. 2 layers gives me double dose of growth factor. So that's part of changing our thinking. But here we enhance the KT margin by apically positioning the soft tissue. So that's a real standard approach for me. I either socket graft it, glue it with an open approach, and then I have the ability to apically position the tissue, or I place the implant. I don't generally place implants and then come back and look for them. I do this way because now I can re-augment it and I can enhance the KT margin by apical positioning, both of which you can do with a staged approach, but I just find if I'm going to go in, I want to get the implant in or optimize the site without the implant. So here you can see the initial healing that's at the site, and we go through maturation, and then we go through final crown. We're able to keep a good distance between them, and this case is 5 or 7 years out, and the patient's doing really nicely. But look at the difference in the KT margin thickness. Okay? So staging it, to me, the primary reason to stage a surgery with a graft and a follow-up implant is minimal KT, because I can take the whole volume of the rehealed socket and apically position it, and usually that tissue in those healings is super thick, and if you add the amnion on it, it really does a nice job. So you can see from an occlusal view the change, and so I think that it's something that we really have in our pocket to make our life easier. Here's an example of what I was telling you, over trimmed, that triangle that I've cut out. You watch, you carry it to the wound dry, you have your assistant hit it with saline, and then you tuck it in, pack it around, and I get a real intimate adaptation. And here I'm taking the cutout triangle and putting it on the margin where I need the most help. So I get an extra dose of growth factor. It's actually easier to put that in first and put your bigger membrane over top of it, because you have less chance of losing it, during the manipulation and healing. So let's go into immediate implants, and we go back to 2008 and even sooner when immediates were started. So there's lots of old-time data that shows it. So where are we at today? Well, this is an older case of mine, so this is about 8 years ago. I had started using BioXclude almost 20 years ago, and I only used it on selected cases. Now I use it on every case for the last 10 years. So here's an example of a mesiobuccal root dehiscence. Who runs into that? Okay. Almost all medial molars have some component of mesiobuccal root dehiscence. So we take it out, we do the site preparation, place the implants, and now what we do is look, what kind of defect do I have? I want to make sure that I have an adequate buccal bone margin, and in the posterior site, you can see the implant in the healed area. Both ISQs are good. So here, this is how I would do it. This is, I believe in this case, just straight cancellous allograft. I have shifted mostly to a blend. I mix all my blood with all my grafts with venous blood. So we take it from the IV and graft it. LPRF liquid is fine, but you got to harvest it and have it. So I use whatever. If I have LPRF, then I do that. But here's what matters. we're able to get the graft in, and you can see on the central image the buccal dimension of the gap, and now we're going to graft it, and we're putting the BioXclude right up onto the healing abutment. And this is the case I showed you in the beginning. So here it is with the BioXclude up on the healing abutment. What membrane can you do that with? And when we do that, we're going to see this regenerate. Here's immediately post-surgery, and just watch as the epithelial cells migrate over it. Here we're early on in healing, and now we'll get to 4 months. So you can see really significant improvements with soft tissue height using BioXclude, which acts as a basement membrane, and the cell's epithelial migrate on. So that's an extra 1.5 millimeters, almost 2 millimeters of tissue that you can get without doing any extra work, as long as your implant is placed lingually or palatally with a buccal gap dimension. Okay, so real critical to see that kind of shape change. So I've been doing navigation since it started. It was part of the original IRB study, and so I do this every day, every case. I think it's a huge improvement in implant positioning, and the data from this foundational study is still being quoted and used regularly, and I just found that this is a real answer to immediate placement. It's really hard to do immediates through a static guide, and this allows me to over-prep the lingual on most of the immediate sites, which is what you have to do so the implant doesn't kick off the lingual plate. And in molars, it allows me to over-prep in the mandible slightly distal, so you're not getting the mesial push out of the interseptal bone. And on most molars, I just take the septum out because it's going to be in the way, and it hasn't had any effect on me doing the immediate molars for 18 years. So that's a normal part. I care about the process, so we just do a scan with a clip in it, do the planning on the navigation software. Now I'm sitting up straight looking at the screen, going by feeling rather than hunching over and bending over to see what I'm trying to see in work. So this is a second article that I did with Mark Lucas, and it talked about Amnion-Chorion and immediate, and so I'm going to show you an immediate placement case that you're going to look at and see this case through briefly. So here's the patient. She has some kind of fracture with the lower right first molar. We're looking at the planning, and so to have the screw access come out in the middle and in the slight lingual of the fossa, this is the positioning that I would do. I need to have an adequate buccal gap of at least 3 millimeters, and most of the time you start out in the septum and end up in the mesial root. So what I was talking about is it's this bone wall here that you have to prep, or else the implant can get kicked forward out of your preparation site into the front hole or gap. So if we go through this case, you can see the extraction site. Here I am using the betadine solution. It's povidone iodine 4%, and I usually rinse it for about 30 seconds and then re-cleanse it, re-scrape it, re-prep it, and that helps get rid of a layer of the anaerobic bugs on a fracture or failed endo kind of case. So we use the navigation to place the implant. We get it in position, we do the graft. The graft is typically in the interproximal, mesial, distal, and buccal, usually not very much on the lingual. It's usually against the plate. And now here you can see how I would typically do a molar right here, where I cut that triangle out. So I have this to place all the way around, and this triangle I can put on the lingual, or I can put in the mesial interproximal, where we usually have a mesiobuccal root dehiscence. So I get a double dose of growth factor in that area. So we put it in, and it bounces into position, and you can see us now place it, and I use like a Molt 2.4 kind of instrument, wet it, and then just tuck it in around the margins. And hitting it, if it's ever sticky, re-hitting it with a little more liquid is about all you have to do. So the suturing is from the buccal through the lingual or palatal margin, and then back out the buccal, and then on the distal, same thing. And what I do want you to see is on the far screen, see the 2 green arrows? The suture isn't coming through the interproximal. The suture is making it bend so that we've got a bungee cord over top of the tarp going to the dump. We don't want the stuff to blow out of our truck, right? So the bungee cord goes from here to there and from here to here, so that we've got it covered at the areas of the greatest exposure. You also have to, in your post-op instructions, tell the patient not to swish more than wiggling their head or gently moving their tongue. But you got to go one step further. You have to tell them not to swish while you're chewing and eating regular food to clean your teeth, because they can brush that out. I have put barricade dressing over select cases, but it has to be a minimal exposure because the amnion doesn't do well with the chemicals in the barricade. So I've covered them a few times with suture foil in those rare cases. So here you can see the situation with this. We were able to get the implant in. It's against the lingual cortex pretty much. We've grafted the buccal, and now we go through healing. So what I want you to see is look how the tissue is filled in, and you'll see when we do the composite. And here's a patient after 22 months restored. So this is really common. Patients that have mesiobuccal root dehiscence, you've got enough bone margin that heals predictably. It fills in with soft tissue. On rare occasion, I've done a CT graft to fill it in the socket just to give it a little bit more support. I've also tried releasing it with a V to Y closure to move the tissue up. But here what I want you to see. Look at immediate post-op and look at early healing. Look at the heights. The photo angles aren't exactly the same, but they're not that disturbed. You can see the tissue coming up, healing on top of the membrane. And so here you can see again the treatment sequence through 22 months restored, and this is pre and post-op. And so this is just a routine in my practice. I do 4 or 5 of these a week in my office on lowers and similar number on uppers, and it's just a brain-dead, predictable solution, and patients come and 4 months later they have their crown, and they like that, and I have a lot of referrals because of that. Even some of my dentists who do implants send me their patients for immediate molars. So it's a real winner in practice, and BioXclude gives us that predictability. Here's an example of an upper molar case, and this is the one with the other gingival changes. So we're doing immediate placement with some minor crestal elevation. The teeth comes out. This lady is heavy smoker, heavy body odor smoke, but doesn't quite smoke enough to have yellow fingers. So right on that border. So in my practice, I don't treat those patients any different than anybody else until they get yellow fingers. So the tar, that total tar addiction is what's there. The vapors are what you can't tell. Okay, so that's the risk. So this is, all my cases are a third smokers, so everything you're seeing, I don't know who is and is, but this lady did, I remember, for other reasons. But implants are placed. One of them is an immediate, 2 are immediates, and you can see the buccal gap dimension, okay? And this is an apical position flap with limited exposure. So this is a wound that we're gonna pack that graft, and you can see the tissue height, and more so on the lateral. We're going to fill it with bone, cover them with BioXclude, suture them with upside down sutures to keep the BioXclude in position. We're going to get the neovascularization and the enhanced wound healing on this heavy smoker lady, and now we can see at the green arrow that gap dimension again. The BioXclude is up onto the side of the healing abutment. And so with that, here's the post-op CBCT, here's early healing, and you can see on the far right how the back one is halfways up and early healing, and the other ones are at level margin, and here at 4 months, it's at the level of the buccal tissue with nice horizontal dimension there. So a patient had a bridge with tissue sculpting, which the prosthodontist I was privileged to work with did on her in spite of she didn't want it. She just wanted to be done. But anyway, look at the very nice contours he was able to achieve with this case and end up with a excellent result on somebody that had a tissue defect. Now, it's a molar. We don't care so much if the gingival height's where it is. We just want it to be stable and have broad, wide, keratinized tissue margin that the patient can cleanse and maintain. But I'll take this any day. I learn in the back to apply to the front, so I don't learn hard lessons in the front. Okay, so just an example. Here's another application for this with using a crestal elevation system, and so I've been a big advocate of crestal elevation for more than 15, 20 years, and I haven't done a lateral graft in an oral surgery practice in 8 years. So there are lots of trick ways to do crestals that I'll show you one toward the end here. So this is an example of the patient. We placed the molar, did a bone graft, added it, grafted around the site, and oral surgeons can do perio too. I did open flap curettage on this site, grafted up to it. Yeah, you can. You just have to have the instruments and look for what you can fix. But anyway, we did this on a yucky crown margin on the adjacent tooth, and we added the BioXclude around the site, sutured in position, and here's the patient going through healing with some appropriate apical positioning of the flap to reduce some of the defect. And here's a patient at 1 year with a good tissue margin, nice, healthy, and you can see the bone filling in on the distal. So this product helps me be a better surgeon and incorporating a lot of the things that I've learned in dentistry till now. So are any of you doing tunneling? Okay, I do a lot of tunneling. This is just one case, but I go through the tunneling. There's a few tricks to it. Homa did the original description of the midline incision, and the original tunneling I did in residency in 84 to 88 for placement of HA for ridge augmentation. So oral surgeons have been doing tunneling for a long time, and there were lessons that you learned doing it that apply really strongly now. Simple instruments, it's just the Molt series, and you need the right and left hockey sticks. So I'm from Canada, so I'm backhand, forehanding it, and it makes surgery fun. But anyway, we make a tunnel, we do our grafting, I bring it up to the ridge crest, and in this area, I actually bring the hockey stick up over and release it onto the palate so I can get bone to pack up and over top. So you get more bone width up at the crest, which is one of the big things with tunneling. If you don't do it right, you don't get that final crestal volume. But I take the BioXclude, take one big piece, cut it in a oblique, and then put the skinny end in with the wider end, and then vice versa. And if you grab it down the middle, you can tuck it all the way to the end, take your fingers, push down, pull it out, and it keeps one nice layer of growth factor all the way across the tunnel. So here's the closure with it in this kind of a case. And what it allows us to do is to really get lots of bone and more up at the ridge crest and over top. So you can get vertical aug, and this is a blend of cortical cancellous allograft and high temperature xenograft and some porcine. And I vary the porcine and high temperature. If I'm going to have implants in the wound, I don't want the high temperature or very little. So I'll put in 10 to 15% of high temperature if it's going to be near an implant. If it's an onlay to protect it, then I go up to 35 to 40% of the high temperature xenograft. So there's a reason and a mix why we blend it certain ways, but we'll get into that more if you want to talk afterwards. In any event, here's the healing, here's the implant placement using navigation, and now we come back, we're doing some minor laser plasty around it for the dentist to place his provisionals, and then this is how the patient finished up with her initial insertion images. I've seen her back, but I don't have images, and the tissues got better and better over time as the tissue matured, which is what we know happens when implants are placed in the right position with the right diameter. I wish I could have convinced him to fix the emergence on the bridge margins, but that's one of the limitations of some of the digital systems is that margin. So I'm going to bump into ridge expansion briefly, just again showing you different applications. This is a patient that's losing a long span bridge in the area and has moderate dimensional loss, so you can see the dimensions of the bone there tipping in pretty good right here where we want an implant. So we're going to take and make an osteotomy through that with piezo and using either screw expanders and osteotomes or regular bone expanders and osteotomes. We want to get it to where we have the implant in the right position, and a lot of times that means we have to take away some palatal bone so that the implant isn't too buccal. So you have to pay attention with ridge expansion to the positioning, and so you can see on that green arrow we had to take away some palatal so that the implant was in the right position buccal lingually. So here you can see the expansion gap, and here's the graft material mixed with autologous heme. So I'm going to graft this area first around the implant with a straight cortical cancellous, and now I'm adding large porcine xenograft to it, blending it, and now I'm going to do a veneer overlay or an overgraft, which is pretty common, and we go ahead, place the veneer overgraft, and then on the far right side of the screen, you can see the Amnion-Chorion or the BioXclude placed over top of the whole shebang. And so this allows us to, I'm not going to watch the video for time's sake here. But anyway, here we're packing that combination. We know large particle maintains better horizontal dimension. So when I'm doing a significant overlay, I want a blend of large particle in with a small particle. So here's just an example of how we trim this, and then I take the extra pieces and put the pieces where I need the most help with healing at the site. So healing abutments are placed, so almost everything I do is single stage and immediate, and that's just BioXclude lets me have gaps that don't matter anymore, even around an implant. So here you can see the post-op dimensions, and everything's great, and then look what the technician sends back for a prosthesis, and then the dentist puts it in. And so, you know, it's like we did all that great work, and now we've got no embrasure space and a ridge lap pontic where there doesn't need to be a ridge lap pontic because there's enough underneath anyway. But hygiene will be a challenge. So let's look at a little more aggressive approach using Amnion-Chorion. So we all see this. This isn't anything special. It's a significant horizontal defect with a residual 3 millimeters-ish bone width that we need to get to 8 to 10. So in my books, I've learned not to try to do 6 or 8 or 10 millimeters of horizontal augmentation. I get 4, and I come back, and at 4 I do a little more. Why would I put more graft material in? What I have to do, make a much bigger flap, right? I have to release it more. The more material you have, the more likely there's movement in it. And adding more doesn't end it with more. Adding more increases the risk of dehiscence, of reduced volume because of mobility at the wound, and a whole bunch of things. So here's just how I would do this case. Did initial planning. You can see, jeepers, we can't even get half the implant in native bone. And it's not a great ridge expansion wound because of the undercut. So I'm doing this staged, and I'm going to show you something I learned a long time ago, and that's a Greenwell superficial split thickness flap. If you don't know about it, here's a reference, there's a paper, and what we end up with is a periosteal margin at the inferior border with a released wound base that's very mobile, and now I don't have to have any inferior border containment. I can pack my graft right into the periosteum. So it's not a hard thing. There's some other folks that have started to apply this, but they've renamed it after themselves, and this is the first guy I know of that talked about it. So here we make an incision. We come out in the tissue parallel to the buccal contour of the soft tissue, and then we dissect it out. The implants are placed, and now you can see the margin. It's also much safer near the mental nerve because we're at a very superficial level. So here's our 2 screws placed. This is no magic. But what I'm going to do is blend your mind a little bit. And Robert Toffee was the one that came up with this thought process. And that was, we're going to place a BioXclude on the bone. And you're going to go, what, are you crazy, Dan? Well, no. The BioXclude isn't a barrier that prevents things from growing together. It's a stimulator with growth factors that helps cause wound healing. So we're placing one under it, doing our blended allograft with the Z-Core's porcine large granules because I'm doing horizontal aug. You can compact more big and small into the same wound space, so it works like a charm that way, mixing it with autologous heme. And now you can see we've got a suture through the periosteal margin for manipulation. Now we're going to cover the graft with BioXclude, so that's a second layer. We're going to hit it. It fits down, sucks down, and now for horizontal augmentations of 4 millimeters, now I use a collagen barrier. And so I cover that, soak that in blood before I put it in, have it trimmed to shape, and now I cover that with BioXclude. So that's 3 layers. I got one at the periosteal tissue layer, and I got one against the bone and one over the graft. So that's a lot of doses of growth factor, and here it is sutured in position with, again, the Greenwell portion maintaining the inferior border, so I don't have to use a lot of biomaterials to come back and take something out. And so this is just showing what we did there. Here's the closure. With it, you do see a little more bruising with the superficial flap. It's slightly more uncomfortable for the patient, but the BioXclude helps combat that. But you do get this little bit of bruising from it because of your dissection plane. So you can see on the cross-sectional images the contour that we have for the graft, And now we're going to come back in to place implants using navigation. So here's our screws. You like seeing it when the bone is out to your screws. We take the screws out, do the dynamic nav. I harvested cores on this, and so these were processed, and we had really good bone fill in and around the Allograft xenograft blend. And now here's the two sites. We go ahead, place our implants, again, navigation, and we'll take and regraft this area. Anytime we have full exposure over a previously grafted site, I do an extra small amount of contour overgraft, and I do that either with the porcine xenograft or cortical cancellous. I don't like bovine around my implants. That's a good way to get peri-implant disease, because I don't think it turns over, integrates well enough, and when it gets stuck with a challenge, it breaks down. So I don't use bovine at all around the implant. So again, another layer of BioXclude over that, so it's going to jumpstart the wound healing, and pretty simple rotation flaps, Palachi flaps in between to have an enhanced interproximal dimension. So that's how the case finishes up. And now we look at our dimensions after healing and regraft. And so I'm real happy with that. Here it is at 7 days. Okay, I like that. You like that? I like that. Looks really good. So here we are down the road with healing at 4 months, and the patient goes through a restoration, and you can see the volume and the contour of the tissue. So it's something that I think really can help. What about this case? Who wants to do this case?
I give it to you.
You give it to me, okay. Well, I got to do it a different way. And so this lady came in, and originally she had an ameloblastoma that was biopsied and had the resection, a marginal resection completed, and this was the residual scar that you can see with very little KT, especially up in the area. So I could do something here. I don't know, this has no KT, so we have to fix it and try to get rid of some of the contracture and vestibular depth. So oral surgeons learned how to do gum grafts too. And so this is a monster big gum graft that we placed because it gets the least amount of scarring. We're already going to be fighting the vestibule and muscle trying to push up. We don't need any extra help at losing wound height from scar contracture. So we did that, placed it. It was covered with barricade. But I want to show you the donor site. Okay, look how big the donor site is. I took every ounce of it I could get. And then all I did was take a big piece of BioXclude, trim it, lay it in 2 pieces, and then suture it with upside-down sutures. And this patient had a stent made because I was afraid, you know, it might be monster or both sides. And we put the stent in, so you can see it in, you can see it sutured, you can see the stent in position, and look at the wound healing underneath it. And the funny thing was that the wound healed just as good where there was no stent as it did where there was a stent. In fact, maybe a little better if you look at it. And the amazing thing was this patient had almost no pain. You would expect them to be doing all kind of squawking and screaming. The BioXclude and the anti-inflammatory and the pain stuff really made a difference for this patient. So she moves from the left side of the screen to the right side of the screen. We've got a better KT margin. And now we go back into surgery, and I'm going to show you, I didn't even try to augment her. I left the bone the way it was, lowered it in some of the posterior situations, and went around the arch with grafting in the extraction defects or near the implants, covering it with BioXclude, just back to one of our earlier applications, which is what I use it for most of the time. Here I did a V to Y closure to increase the KT margin, and there's 5 implants in that gap, and the one that's in this defect I put at the same angle as the defect because I didn't want to augment it, and I corrected it with a multi-unit angled abutment. So rather than changing the basilar bone level, that worked and seemed like a better idea to me, and the patient went on with her initial healing to final restoration and did really good. We have the option of removing the molars. The other molars are fine, but with a hybrid, you can be far enough away that you can get a good transition, that it's cleansable, and the molars can stay. So that's something that is really helpful. How much time do I have left, guys? Doing okay? Got 10 minutes? Yes? No? Okay. So I'm going to show you some of the crestal approaches. Alan Winter and the group that used to be together a long time ago in Manhattan, or periodontist, I went with them and some other people to Europe and were in Rome with Bruschi and Sciprioni and learned some of the expansion and different crestal techniques that I employ today in modified form. But we're going to show you a crestal window. The first description of this was actually Hilt Tatum. Okay, so there's nothing new, guys. You're just rediscovering something that somebody else already did, and some variations. But what we're going to do is raise a section of the bone floor. And so this is something that is a really excellent technique, and I use it a lot, and it doesn't hurt. And you can be back in 3 to 4 months if you have to do it staged. You don't have to wait a long time because it's less graft volume, and it heals really quickly. So this gal had a number of failing distal cantilever appliances, which had served her well, amazingly, for 10 or 15 years. But here's what we're doing. We've got a big blowout extraction site here, and now what we're doing is just taking piezo, doing an outline like you would a lateral window, and then mobilizing it and adding bone, and basically doing a crestal window elevation, pushing it upwards with the contiguous elevators. So those are something, if you want to know, you can ask me after. I'll tell you where you can get them. So straight graft everywhere, cover it with Amnion-Chorion, and now just a closure. And you see that behind the tooth, it's still the same extraction site. We didn't close it up primarily over it. We just left it open to heal because it will heal predictably with BioXclude over top of it. So here's an example of the immediate post-surgery like we talked about. And now we go through, look at the early healing. And at 10, 14 days, this is where she was at. She went back to California, and that's pre-op and post-op. And so we were able to use a septum on the distal to raise it up to try to get in 1 or 2 fixtures back here for her. So this is now when she came back after healing and just looking at planning for what we have to work with. So we had nothing before, and now we've got a really nice site. So let me show you another application of that kind of a contiguous sinus floor elevation approach. Here's a patient coming in with a failing second molar, and the first molar site looks like just like you'd expect, 1, 2 millimeters. And remember, you've got a slope, so it's always more on the mesial or distal, but in the middle, it's going to be pretty limited. So we're able now to take and do a palatal incise to keep all the KT on the flap with a vertical, because we're going to move this all forward. And we're going to take now, do the piezo, and I'm taking just a concave cutter osteotome and breaking it because it's a very thin floor. And you just have to put your instrument perpendicular to the floor. So where it changes angle, you have to go more posterior with your elevation. So we start mobilizing it, and then we move up to the contiguous floor elevator at 2, 3, or 4 width, and then add some bone to it. So again, see, I'm coming distal because that's where the sinus is. We have to be perpendicular to the sinus floor. And now we'll fill that in with some bone. And we can also expand it a little bit. Using that, you can get a 1 to 2 millimeters of expansion at the site if you need to, sometimes with an anterior vertical release with piezo surgery. You can see on the radiograph the bone level there with the cortical cancellous allograft, and now we'll move on to the next steps. So we use osteotomes, we use contiguous sinus floor elevators, we add bone graft blended with autologous heme, and we push it up 2, 3, 4 times with that to usually get about 6 millimeters to 7, 8, 9 millimeters elevation, depending on what we're planning. I try to get into a 9 to 10 millimeter implant in sinuses that are grafted. So that's what I'm looking for. So you can see the marks, and so the wide mark where we've gone up to about here with placing the graft material. And now we're just adding bone to the site, and we're going to take and use a contiguous elevator with a slotted 4 by 10 millimeter site preparation, increasing the footprint so we don't tear it, and able to get a nice volume of graft material. And you can see on the x-ray the volume that we're able to raise. Did a nose blow test to be sure I didn't have anything. Now I go to a site-specific osteotome to raise that last little bit and generate it, and I also check it with navigation. Here we're putting the implant in, so we were able to get it pretty well where we wanted it from a vertical and apical. Now you can see the implant in, the residual bone gap, and the extraction defect behind it. Now, for a while that would have scared me, but since I've been doing ridge expansion for years, the gap doesn't bother me at all. So how do we manage that? So what I'll do is I'm taking some of the tuberosity and I'm going to mix that bone in with the graft material to get some cells, and then we're going to graft all around the area. So we're going to take and pack it in, and so these are the grafting instruments that I use. Watch this trick now. I should hold it and the assistant will suck on it. I'm waiting for her. Come on, babe. There, she did it. So they can clean it up where you're suctioning on the instrument without damaging the site. So let's look at the still images just to finish explaining this. And it allows us to go through, get here to the implant, to have it where we want it in position, now dealing with this. So I've made this vertical because my plan is I'm going to pull this all forward. Here I'm doing a finger flap to pull into the interproximal. And now we're going to take the tuberosity soft tissue and pull it up with a V to Y closure to get primary closure around the implant. Because this area that's all graft, I have to have primary closure over that gap, even if it's only a interproximal rotation finger flap that covers most of it. So that's the beauty of using BioXclude. So here you can see the closure. So we've moved everything down. We did a anterior rotation that's into here, and the rest of the flap is moved apically. Moving the flap apically does what? It enhances the KT margin and makes the vestibule deeper, all of which are good for long-term success. So this is what we're able to do, and then the posterior, we have a little bit of a defect here, but we pull everything up, close it, and now we've got primary closure with keratinized tissue and a little bit of defect back where it doesn't matter, and it doesn't hurt. So that's giving you a quick overview with the case. So here's the bone margins. You can see the different shapes of the bone in it. And here's what we look like with our early healing with the suture still in. So this is all coming along very nicely with limited inflammatory response. And here's the case at 4 months and restored. So this is another year out, and I have 2 year out, but I didn't have the x-ray, and I tried to get my staff to email it to me because I forgot to put it in. So anyway, these growth factors are really huge in Amnion-Chorion. It's antibacterial, anti-inflammatory, and really helps a lot with healing. We showed you examples of gaining tissue on this case where there was no very limited KT margin, comparing it to an apical position flap with tons of CT and look at or KT and look at how it healed out even at both sites. I think that's pretty incredible in terms of being able to have a predictable healing. Here we showed you this gap with a vertical dimension. If you maintain the buccal lingual gap, minimum 3 millimeters on molars, 2.5 on everything else, that margin gives you the ability for the tissue to grow in it. If you're too facial, you'll get some improvement, but the angulation to the facial, you'll end up with it receding down the road anyway. So important how you place it. Here's one other case that I didn't show you, but here is this is a canine lateral, and so this is a full arch that we were doing in sequence, and you can see a 5 millimeter healing abutment about 1.5 millimeters, 2 millimeters below. Look at the early healing, and then look at the final restoration. So look at the tissue margin that we have. That's a central, here's the canine. So it started out with that much healing abutment exposed. That's when it finished healing. So lingual placement, adequate grafting of the buccal gap, you can see the tissue regenerate back to a normal biologic dimension because it heals on top of the basement membrane. So it's immunoprivileged, anti-inflammatory, antibacterial, and it really helps improve healing. It's not a barrier in the sense of what we want to think of periodontally, but I think as time's gone on, some of the classic GBR principles have been shown that you don't have to if you have intact periosteum. And so the worlds of oral surgery and perio that have been colliding for so many years are starting to mesh and learning more from each other, and I think really coming up with an excellent product. So we talked about wound healing, upregulation. I do it on almost every case. I use it in all these different kinds of applications, and patching and repairing complications and sinus membranes and things is another area, but I couldn't fit it in. So if you ever want to come visit a beautiful place, we're up in North Idaho, so come visit us, and I'd love to have you join us, and I'll hang around and answer any further questions if anybody has that. So thank you, folks. So, questions? Shoot.
The U.S. state is an anti-inflammatory. I believe you refer to BMP, a muscle inflammation result.
Yeah.
But I do need information to process the healing.
Yeah.
How do you histological studies show anti-inflammatory and healing go hand by hand?
Well, you know, I think we're at a place where a lot of the suppositions that we've had about things are falling by the wayside, and I'm having to say, oh, that's interesting, instead of, no, that's a stupid idea, a lot, because stuff is really changing. BMP, to have more inflammation, means you're going to have better bone healing. I'm not saying that's wrong. I'm saying that we see really good results with limited inflammation and pain. So I don't understand and can't bring that one together for you. I'm just telling you what I'm seeing working with the product. I have used BMP. It does work. There's no question about that. It just functions in a different way.
Yeah, but I don't understand when you say anti-inflammatory, you mean anti-inflammatory. And I need my inflammation through my initial healing.
Well, okay, so I'm not using...
Are you telling us limited inflammation or anti-inflammatory?
Well, it's anti-inflammatory and it limits the inflammation, but we're not dependent like we would be on with BMP. We're not dependent on that for healing in these kind of wounds. So that's a whole different paradigm with a whole different biology that goes with it.
What is that different biology? I do need inflammation for healing.
With BMP, I agree with you. Outside of BMP, I don't need inflammation for healing because the injury to the wound. So remember, I took you back when I talked about this from an immediate viewpoint. The immediate extraction site when you're taking out teeth is the best healing model that we have. So I will do much more aggressive with people on bisphosphonates and different other products. I would do it as an immediate rather than wait to see how they do with healing and place the implant secondarily, because I have the best chance of it working straight out of the gate with that model. So you need a certain amount of inflammation. I don't think you need extra inflammation. I don't think you need extra swelling and all the sequelae that go with those inflammatory factors, but you have to have some or the wound wouldn't heal. So that's the best I can do to resolve it. I'm not aware of any data or studies that would compare that to be able to give you an answer. It doesn't mean they aren't, but I'm not aware of any. Well, it reduces inflammation, and it does that in the pain model that I showed you, where they showed the amnion in a split mouth study. It reduced pain and had enhanced healing. Thank you. Any other questions, guys? Awesome. Well, thank you. Snowasis thanks you, and I'll be around if you have anything else you want to say. Enjoy the great meeting here at AO. Thank you.